Bismillahirrahmanirrahim. Allahumma lakal hamdu kama ta'alu wa salli ala Muhammad kama ta'alu. Allow me as'aluka rizqan tayyiban ilman nafi'an amal mutaqabbilan. Well, today our lecture is very special because it is going to be very useful for all of you, even now and even later during your clinical years. So our today lecture is is talking about the normal urine composition and beside what are the basic criteria and analysis which has to be implemented for the analysis of the urine, which is basically called urinalysis. So the term urinalysis is actually used for the purpose of urine examination. Why we are saying normal urine? Because urine is normally normal. Make it in a very easy way. So we'll move on to our learning outcomes. I assure all of you that after the today's lecture, you will all be able to easily understand the basic normal composition of urine. Secondly, that are the basic investigations and tests which are used on a urine for the diagnosis of a disease. But for sure, because the standard is normal urine, so that is the reason our focus is on a term called normal urine. So we move on in our first slides. A little bit will be on your basic knowledge, in which we are going to compile all that knowledge in few slides, and from there we will move on to our urine examination. As we know that the total body water is 60% of our body weight, and you know it very well that it is highest in newborns and adult males, but lowest in adult females and adults with a large amount of adipose tissue. And we normally divide the total body weight into basically two compartments. The first compartment is basically your intracellular, and the second compartment is basically the extracellular. When we talk about the extracellular, we have the most major, the ions, which are sodium, chloride, and bicarbonate. But in intercellular, we do have the potassium, magnesium, protein organic phosphatase, which inclusive of ATP or AMP in abundant amount. And within the extracellular, further it is divided into interstitial and the plasma. In the plasma, the major proteins are albumin and globulin. And interstitial fluid, we have other lot of inorganic molecules and lot of other components which vary from one person to other person. So, summarizing everything in the form of function of kidney, the overall function of the kidney is controlling the blood volume and composition. That is the basic generalized function of the kidney, that it controls the blood volume and the composition. But it can be further elaborated in the form of number one, eliminating the waste by filtering the blood plasma. Secondly, regulating blood volume and blood pressure. Thirdly, regulating fluid osmolarity. Then we have the function of acid-base balance and hemostasis by regulating PCO2 levels. Then we have the detoxification of free radicals, drugs, and also toxins themselves, which are coming from different infectious agents. And then the last one is the secretion and hormones, inclusive of renin, erythropoietin, calciferol, that is the vitamin D precursor. Number four is it is also involved in gluconeogenesis. I will not be going into the detail of these processes because I'm sure you have been, studying it, and you have been going through all these processes in different lectures previously. So we are actually summarizing and accumulating all that knowledge so that we can move into today's lecture. Okay, now we move on to the human metabolic waste. Normally, they are classified into two parts. The first part is the carbon dioxide waste, and the second part is the nitrogenous waste. Carbon dioxide waste are always excreted or removed from our body through the respiratory system or the urinary system. So this is something very strange. Carbon dioxide waste are normally removed from our body through the respiratory system and the urinary system, but the nitrogenous waste are only removed through the urinary system. So one of the key function, if we look here right now, is the removal of the nitrogenous waste, which is only through the urinary system. So these all byproducts are coming from different metabolites and chemical reactions in the body. They have to be excreted so that the person will not get sick and eventually the hemostasis will not be affected. Remember, we go back to our previous knowledge in which we said that we have the genes. From the genes we got the proteins. From the genes we got the RNA we got the proteins, and proteins we got the metabolites. So these metabolites are, when employed in different chemical reactions in the body, you basically ended up in carbon dioxide waste or nitrogenous waste. So within the nitrogenous waste now, we have two different kind of groups. The first one is the nitrogenous waste, which are coming from the protein metabolism, and secondly, the nitrogenous waste coming from the nucleic acid metabolism. From the protein metabolism, we normally get urea, which is considered to be one of the very important nitrogenous waste. And secondly, we have the uric acid, which is coming from the metabolism of purines. Okay, now if these nitrogenous waste increase in our body, and if they will be rising high, they will result in azotemia and finally in uremia. So urea comprises nearly 50% of total nitrogenous waste in the humans. Please also consider creatine and creatinine coming from the muscular metabolism to be as a part of the nitrogenous waste. But we are not adding it directly under protein metabolism and nucleic acid metabolism, but they are also considered to be a part of nitrogenous waste metabolisms. Well, now our actual topic is talking about urine. If someone asks you what is the definition of urine, for sure there are so many definitions of urine. Many books have having their own definitions. But remember one thing, that, for example, this is one of a definition which said a liquid containing multiple waste products of metabolism, especially urea and other nitrogenous compounds that are filtered from the blood by the kidneys. Urine is stored in the urinary bladder and is excreted from the body through the urethra. Remember one very important term, which is a transudate. Remember, we have the exudate and we have the transudate. A normal urine is always transudate. Means the specific gravity, means the transparency. So it's always there. If it is not transudate, it's not a normal urine. So one of the main feature is, like all other body fluids, which usually are transudates, urine is also a transudate. Beside that, it could be a liquid which is having a high nitrogenous waste components. You can have so many definitions. So exact definition of urine is still not possible basically, but yes, hypothetically we can define urine in different forms. So just a summary of the basic 4 steps of urine formation. Number 1 was the glomerular filtration. Number 2 was the tubular reabsorption. Thirdly, tubular secretion, and then we have the water conservation. I know you have already covered it in physiology, but just summarizing everything for you to overview for today's lecture. Okay, now something a little bit different. We talk about the ultrafiltration of plasma. This ultrafiltration occurs through glomerulus, giving rise to primary urine. And the primary urine is always isotonic with plasma. What actually the conclusive statements are that, remember, we do have the collagen type 4 fibers which are present in the capillaries of the glomerulus, and then we do have their pore size is a maximum diameter of 2.9 nanometer. So the plasma components which are lesser than 15 kilodalton, they are normally excreted out of, or they can come out of these small pores. But looking at the electron microscopic features of these capillary and the pores, it has been reported recently that the plasma component, which are more than 64 kilodaltons, are totally blocked. They cannot pass through these pores. So ultrafiltration is a corrector of basically the pore size of the capillary not any other components. Besides, the very important feature to remember is that anionic molecules are always repelled by the negative charge of the basement membrane. Remember, we have the structure of the capillaries, and we have a special place, the basement membrane. So the basement membrane is having a negative charge, and it also repels the anionic molecule. Because of that, these molecules are retained within the capillaries, and they are not able to pass uh, through the capillaries. Okay, this is something about what are the basic components and essentials inclusive of the nitrogenous waste, inclusive of the organic constituent and inorganic constituent of the urine. By volume, we normally have 0.5 to 2 liters per day of the urine with a pH of 5.8, but it is always fluctuating between 4.8 to 7.5. By density, the it is 1.015 to 1.022 kilogram per liter. Osmolarity is 50 to 1300 milliosmol per kg, and by solid molecules and component is 50 to 72 gram per day. So we have the uric acid, we have the hyperurates, we have the creatine, we have the creatinine and urea. These all values which are mentioned in the slide and in the box are the normal values. So in diseases, they can fluctuate. They could be very different, could be very high, and could be even low sometimes, depending on the kind of disease which is affecting the metabolism. Okay, now we move on. The organic components, which are basically with which are basically mentioned in the box down there, this box. So glucose is always less more than 0.16 gram. Remember the threshold. Ketone bodies are there, proteins are there, and the amino acids are there in the normal urine. So we go to the inorganic constituents. These are all the inorganic constituents comprise chloride, we have the phosphate, we have the sulfate, we have NH4, we have sodium, potassium, calcium, magnesium, and many other things which could be present in non-normal urine. So among all these inorganic constituents, chloride and iron is basically the highest with a millimole osmolar concentration of 120 to 240, and the sodium cation is the highest concentration, which is 100 to 150 millimole per day as per their excretion levels. So urinalysis is basically whatever we have discussed till now in the previous slides. Urinalysis is basically the routine urine examination of all these components which we have just gone through, and it's the most useful tool for the clinicians as an indicator of health or disease, particularly used in renal metabolic disorder, often done for patients admitted to the hospital. So the routine urine examination is divided into four main groups. The first one is the physicochemical properties. Second one is the chemical examination. Third one is the microscopic examination, and the fourth is the bacterial screening. So urinalysis is having four different components. The first one is the physicochemical. Second one is the chemical examination. Third one is the microscopic examination, and the fourth one is the bacterial screening. So we move on to all of these components one by one. The first one is basically the physicochemical properties, in which we have color, appearance, volume, specific gravity, and odor. So we also call it odor sometimes. So we have five of these components: color, appearance, volume, specific gravity, odor, or smell of the urine. So which all of these five properties can give us a very strong clue of different types of diseases or different types of metabolism which are affecting our body in general way. Number two is the chemical examination, which is inclusive of the pH, sugar, protein, ketone bodies, bilirubin, urobilinogens, occult blood, nitrite, and ascorbic acid. And the third group is the microscopic examination, which is inclusive of white blood cells, epithelial cells, red blood cells, cast, crystals, bacteria, yeast, and non-bacterial organism. And the fourth one is bacterial screening, which is inclusive of the gram staining and the colony counting. So overall, generalized, we have all these things together, which give you the final report of the urinalysis. Sometimes some of the labs, if the first one is done, Only the first part is done, that is the physicochemical properties, and if the urine is not normal, normally they never proceed with the other three groups of properties. But ideal is we should at least target the first three, at least the first three, because sometimes physiochemical properties are still normal, but the microscopic examination is not normal. So this is very important to understand. So how the urine is collected, I'm sorry, because most of this lecture is basically lab based, and all of you will be for sure going to be exposed to this practical, maybe also in the university, and also later in the clinics. One day you must be, because no doctor will be basically avoiding this test. Everyone has to go through. So the urine must be collected in a sterile bottle. Normally the bottle looks like something on the right side, this a small bottle. The routine urine examination must be conducted within 30 minutes after collecting of the urine. But remember, why 30 minutes? Because, example, a person is having a very high bacteria inside the urine. So what will happen if you will keep the urine more than 30 minutes, or even 2 hours, 3 hours, these bacteria will be always multiplying. And once the bacteria will be multiplying, they're going to utilize a lot of glucose. They can change the pH of the urine. When the metabolism is happening, the pH can also change, which will change the urea to ammonia. So you cannot actually have the exact value of the urea in the urine. So if example the pH is increased, the phosphate will precipitate, and you cannot measure the level of even the phosphate. So even oxidation of urobilinogen to urobilin will happen, which will give you the negative results for jaundice. So it may remember, when you get the urine sample, it has to be tested as soon as possible. But what actually the normal practice is in the wards, even in the clinics, when we get the urine sample, it is tested a bit late, because either it is sent to the laboratory, or either it is sent to a hospital or your territory hospital laboratories, and it takes normally more than 3 to 4 hours. So keep in mind, wherever you work, please try to implement this rule, that it should be within 30 minutes. If not 30 minutes, then what you have to do? In that case, you must refrigerate the urine sample, put it into the refrigerator, or the other option, we have lot of preservatives which we add into the urine, and it can be even used after 6 to 8 hours. Okay, now what are different types of urine specimen? The first one is the random specimen, which is very good for the chemical and microscopical examination. It can be taken at any time after first morning urine. These are different type of urine specimen, and they're very important, very important for the clinical use. The first one is the random sample, which is used for the chemical and microscopic examination. It can be taken at any time after the first morning urine. Second one is the first morning specimen. This is a specimen of the choice, because it is most concentrated. You can get a very good idea of specific gravity, very good idea of the inorganic and organic constituents, especially the microscopic examination. So this first morning specimen, even for me, is always the specimen of choice. So third one is the afternoon specimen, which is taken between 2 to 4 p.m. and is best for the detection of urobilinogen. So this is another very important thing. If you know the basic metabolism of urobilinogen, you know the basic endocrinology, then you can easily have an idea why these different specimens are taken at different time. So then the fourth specimen is the night specimen. All urine samples are collected in 12 hours of night. For example, we'll start at 8 p.m. till 8 a.m. So all specimen during that time, anytime the patient or a normal person is going to urinate, we just collect that sample. And then in the day, the day sample is starting in the day. All urine samples collected in 12 hours of the day. For example, 8 a.m. to 8 p.m. Remember why we need the morning and evening specimen? A simple example is status of different endocrine hormone, different endocrine molecules. You need these kind of specimen. Remember, the level of hormones is different at different times in the day and the night. And we have the postprandial sample, which is taken after the 2 meals or 2 hours of the meals. This is a very good example for example, diabetes monitoring. You give a very high concentration of glucose to the patient, and later you see what is the threshold, what is the level of, what is not the threshold, what is the level of the glucose which is excreted in the urine. The last one is the 24-hour specimen, which is used for the clearance test of the kidney. Samples are collected for 24 hours, for example, 8 a.m. to next day 8 a.m. It is to avoid any changes in the dilution of various suspended constituents of urine. So these are different specimens. Normally, we have 1, 2, 3, 4, 5, 6, 7 different kind of urine specimens, which we can use for different purposes. I'm not focusing on how to take those specimens which are specific with respect to gender, which are specific with respect to age, and with respect to different conditions. So I'm not focusing on that part in this lecture. So I think once you're in the clinical years, you have to go through and learn that part also. So number one is the physico-chemical properties. First one is the color of normal urine. Normal urine color ranges from pale yellow to deep amber. It is a result of pigment called urochrome. So B with vitamin turns urine an eye-popping neon color, but may also indicate a liver disease. Porphyria, a disease that affects your skin and nervous system, turns urine color to a port wine. So these are a few examples I'm going to show you here. Beside that, the urine color changes are harmless and temporary sometimes, but if they're due to certain foods, for example, beets may turn urine red, dyes in foods and drinks, supplements like vitamins and prescriptive drugs. So sometimes the color of the normal urine is actually harmless. Unusual urine color can indicate an infection or serious illness. These are different examples of color of urine. For example, pale yellow to milky. Basically, they're different colors of urine. So when once you will be in the clinic, and even maybe if, because I think we are having online practical session this time. If it is the real scenario practical session, we normally show all these different colors of urine samples. So we move on to the next part, which is the appearance of normal urine. There are a few terms very important which we need to understand. The actual term is the clarity of the urine. How clear is the urine? Or if it is transudate, it will be clear. So what we want to say here, you down there, there's a picture. If you can all see this picture clearly. So if you see here, in the first picture, which we call the term is clear, there is a picture at the back of this test tube, and you can easily read the words. You can read the words back in the tube. So if you can easily read the words at the back of your tube, or example, if it is your hand, you can see the lines in your hand. So then in that case, we say the urine is clear. So this is a clear urine. But if it is slightly cloudy, what will happen? You can still see the words, but it is difficult for you to read those words. If you see here, if you can still recognize the words a little bit, but you cannot read it properly, it's called slightly cloudy. So it could be because of maybe very high bacterial infection, maybe some other reasons that turn basically the urine to be slightly cloudy. Third term is cloudy. So if you see the cloudy one, you can basically see the paper at the back, but it is difficult for you to read those words now. So you can still see the paper, but the words are still clear. And the fourth one is the turbid. In turbid, you cannot even see the paper at the back of your test tube. So you cannot, your eyes cannot see that paper, or your eyes, the light cannot pass through this kind of test tube. So this is called a turbid. So you must know that the terms clear, slightly cloudy, and turbid. So when you got a urine sample and you are asked to write a report, so remember, the first thing we are going to pick will be the color of urine. The color of the urine was amber yellow, and the urine was found to be clear, cloudy, or turbid, whatever you found. And then from there, we can move on to the next slide. So now, substances that cause cloudiness but are not considered unhealthy include mucus, sperms and prostatic fluid, cells from the skin, normal urine crystals, and contaminants like body lotions and powder. Sometimes some people are using lot of body lotions and powder, and it also come inside the urine specimen, which actually give a lot of issues. That is the reason I told you that when you will be in the clinical years, you'll find like there is a way to take the urine specimen. It's not like you just, sometimes we just give a bottle to a patient and said, please go and get us a urine specimen, which is actually wrong. We have to actually let them know, and we have to give them proper instructions, either written instructions, especially if females are there, like how to take the urine specimen. So other substances that can make urine cloudy includes red blood cells, white blood cells, or bacteria, and it really indicates a condition that requires a serious attention basically. So going to the volume of urine, normal volume of the urine is 750 to 2000 ml in 24 hours. If it is below 750 ml, we consider it oliguria, which could be because of dehydration, infections, obstruction, renal stones, kidney failure, etc. If it is over 2000 ml, we consider it as a polyuria, which could be because of diabetes insipidus, hypertension, nephrotic syndrome, ingestion of alcohol or drugs, or endocrinal disorders. If it's absent of urine, we call it anuria, which is because of obstruction, kidney failure, or stenosis. So the general term is basically the volume of urine. The general term is the volume of urine, and then within the volume of urine, we have normal urine, we have oligouria, polyuria, and urea. These are the terms which you have to remember. Going to the odor of urine or the smell of the urine, healthy urine may have a mild smell but generally does not have a full odor. In some cases, an unusual or strong urine odor may be due to benign conditions that are not harmful, such as eating certain foods or taking certain medication and volatile acids. In some cases, an unusual or strong urine odor may be due to benign conditions that are not harmful. I think it's just a repetition of the previous one, such as eating certain food or taking certain medications. Especially the people who are on vitamins or some kind of complementary medicine, they have a very strong urine odor. Move on to the next part, which is the specific gravity. The normal specific gravity of the urine specimen is 1.003 to 1.032. A usual practice in the past, some of the labs and some of the clinics, they just measure the specific gravity. If the specific gravity is more than 1.032, they normally go for the further examination. But this used to be a very wrong practice which needed to be changed now. So specific gravity basically reflects the kidney's ability to concentrate. And when want concentrated urine for accurate testing, best is first morning specimen. As I mentioned before, the first morning specimen is highly concentrated. So the random specimen is 1.003 to 1.032 specific gravity. 24-hour specimen at 1.015 to 1.025. So several renal tubular damage. Uh, those cases, specific gravity is fixed at 1.010, and this term is called isothenuric. So remember that this term isothenuric in your future use. So it is always there when it's a serious renal tubular damage. Okay, now what we have, but how we measure the specific gravity? Previously, we used to measure manually, but now we have the strips. We just use the strip. We actually dip the strip into our urine specimen, and then we match the color of our results with the results which are mentioned on the standard values. These are the standard values which are mentioned on the box of the urine strips. And example, somebody got this value in the urine specimen, and they're going to match it back here with the standard value. So this is how we normally measure the specific gravity using the strip method. Okay, now we have the osmolality of the urine. It determine the urinary osmolality is more important than specific gravity because it gives more accurate reflection of the concentration of dissolved substances. This is very important to understand. It is the measure of the moles of dissolved particles, that is the undissociated molecules and ions, which are contained in kilogram of a solvent. The normal osmolality of random urine specimen varies from 40 to 1350 milliosmol per kg. The normal osmolality of 24-hour urine specimen varies from 500 to 800 milliosmol per kg. So sometimes some of the kits they don't have the option of specific gravity, but they do have the option of osmolarity. But you don't need to get worried because osmolarity is a more better term than specific gravity. But you have to just focus on the normal values which are mentioned on the strip or the standard any document they have given with the strip to my ear. Now we go to the chemical examination. We have the reagent strips are used only once and discarded. So if you use one reagent strip, you use it and then you have to discard it. So the test has to be performed within 1 hour after collection. It allow refrigerated specimen to return to room temperature. Remember we said if it is more than 30 minutes, you have to store into the refrigerator. So in that case, you basically need the specimen to be a room temperature because remember, when you're going to use the strip, it is going to have a chemical reaction. So when it's a chemical reaction, it has to be at the room temperature. If the temperature is low, the chemical reaction will be very poor and you'll get the false negative and false positive result. So in this case, you allow refrigerated specimen to return to room temperature first and then you use your strip. Dip strip in fresh urine and compare colors of pads to the color chart after appropriate time period. Instruments are available which detect color changes electronically. What we are doing using a strip is a semi-quantitative method, which they have mentioned on their box in the form of color charts. But sometimes we do have the equipment. We do have that equipment also in our lab. So you use that strip and you insert the dip into the equipment, and it can also give you the quantified value by reading that result, like how much is the actual concentration. So briefly dip the strip in urine. Colors are matched to those on the bottle label at the appropriate times. Timing is critical for accurate results. So this is how normally your box looks like for any of the urine strips. So this is how the box look like. Within this box you have nearly 150 to 100 strips. So you'll pick one strip, you will dip inside the urine specimen, and after that nearly 30 to 40 seconds, maximum 60 seconds, you will match these all colors with the values which are mentioned outside of the box in the form of color pads. So this is how normally we go for using a reagent strip for the urinalysis. So there are different strips available in the market. For example, this is one of the strips we have mentioned here. So if you see here, we have what it is. It's even measuring the level of leukocytes, that is the WBCs, nitrites, urobiogens, proteins, pH, blood, specific gravity, ketones, bilirubin, and glucose. So this is a normal standard. In the first row, you can get the normal standard value. This is all the normal standard value. But on the other side, with rising, what kind of stuff you're getting, everything is available. So you will be matching your sample results with all of these different colors at one moment. So you will see which color your strip is having, and you will report it accordingly for your specific sample. Okay, now we go to the glucose. Presence of glucose. These are the different concentrations which are assumed to be available on the strip which is available normally in the market. So presence of glucose is called glycosuria, which indicates the blood glucose level has exceeded the renal threshold. So they remember the threshold of the kidney is there. So if it is more than that, then the glucose will start appearing in the urine. So, but sometimes the trace elements are still there, which is sometimes some of the kits will not detect. So it is useful to screen diabetes. Secondly, we have the bilirubin. Bilirubin is the byproduct of the breakdown of hemoglobin. So normally the urine has no bilirubin. The presence may be an indication of liver disease, bile duct obstruction, or hepatitis. Since the bilirubin in sample is sensitive to light, exposure of the urine sample to light for a long period of time may result in a false negative result. So make sure your urine specimen, if you're expecting or not expecting any kind of high bilirubin, you should store it in the dark, not in somewhere near to the window where the lot of sunlight is coming. Then we have the ketones. Ketones are excreted when the body metabolizes fats incompletely, and this is called ketonuria. So normally it is negative, but sometimes these are the values which are mentioned here. Depending on different samples, you'll get different results. Okay, then we have the blood. The presence of blood may indicate infections, trauma to the urinary tract, or bleeding in the kidney. The false positive reading most often is due to contamination with menstrual blood flow. So this is something very important to understand. That's why I said that with the gender and with the different age groups, the results also vary. So normally it's a negative, but sometimes we have the trace, sometimes moderate. So these different values. So because in current lecture, I don't have the time to explain all those reasons, and it's a normal urine analysis. That's why we are not covering currently in this lecture. Okay, then we have the pH. The pH measures the degree of acidity or alkalinity of the urine. Or in other case, you're actually indirectly measuring the quality of renal functioning, basically. So the pH can vary from 5 to 8.5, which are available in the current kits available. Okay, now we have the proteins. The presence of proteins, that is, the proteinuria, is an important indicator of the renal disease. False negatives can occur in alkaline or dilute urine or when primary protein is not albumin. So we have normally it's negative. If it is positive, depending on a urine specimen, then doctor has to take some serious actions. Then we have the urobilinogen. It's a degradation product of bilirubin formed by the intestinal bacteria. It may be increased in hepatic disease or hemolytic disease. I try to make the lecture very simple as possible so that all of you can digest and make it useful, basically, for the future analysis. So normally it says it is also available, and sometimes it can be very high. If it is very high, then it's an indicator of some serious issues. Then we have the nitrite. Normally it is negative, but if it is positive, it is basically made by the gram-negative bacteria, which convert the urinary nitrate to nitrite. So if nitrate is positive, it's a straight indication of bacterial infection. So leukocytes usually indicate infection. If the leukocyte estrase active, we actually measure the leukocyte estrase activity. So these leukocyte estrase is basically on these different pads, and once the sample interact with them, so it will give you the results. The leukocyte estrase activity is due to presence of WBCs in urine, while nitrite strongly suggests bacteremia. So now, results of nitrite versus the results of leukocyte estrase, they count a lot for your diagnosis in urinalysis if it is any kind of infection. So normal values, negative results for glucose, ketones, bilirubin, nitrites, leukocyte trace, and blood. They normally must be negative. Protein negative or trace elements. pH value should be between 5.5 to 8, and urobilinogen is 0.2 to 1.0 LRH unit. So this is what we assume to be the normal values in the urine specimen. And then we have the handling and storage of the strips. Remember, these strips should be in their original container. Sometimes we take out the strip and we never, we never put them in the container, because remember, these all reagents which are on the strips, they got oxidized and they got they got destroyed by light, by moisture, by different volatile fumes, and then you will get the negative results. And they must be used before the expiration date. After the expiry, please don't use them. Procedure: dip strip briefly. This is example the urine sample. You have to dip the strip briefly inside the urine specimen, but please don't be like the guy in the picture. Please don't forget to wear your gloves first. Wear the gloves. Take the strip out of the strip box and then pour it inside the urine specimen. And after that, you just like blot it briefly on its sides, and then just match the color with the chart provided or outside the box of the strip, and then you will get your results. It's very straightforward and it's very easy. The only trick is don't over dip the strip more than 1 minute, or don't don't just, there should be minimum 60 seconds. Just remember this part. If it is 60 seconds, you will normally get a very good result. But in some case, if you need a more time, they clearly mention in the strip by the manufacturer, like, you need more time for A, B, C kind of specific molecules. So that's why you need it more time to dip the strip. So what are the sources of error? We already know, we have gone through. Timing is one of the sources of error. Secondly is the lighting. Number 3 is the quality QC is the quality control. Reagent strip should be tested with a positive control on each day of use to ensure proper activity. We don't know, sometimes the kit is not working properly, or they all got spoiled because of light or something. So what happened? You get the sample which you already know that the results are already known by you, and you use your kit to see if the results are replicating or not. Number 4, sample. Proper collection and storage of urine is necessary to ensure preservation of chemicals. Okay, then we have the testing cold specimen. I told you because the cold specimen has to bring to the room temperature to be tested. Inadequate mixing of the specimen. If example you are having a lot of suspended molecules, suspended particles, even inorganic or organic or cellular contents, you have to mix the urine properly. Just move the bottle 1 2 times before you test, so that you will get a proper mixing of the specimen. Or otherwise, when you're dipping the strip, maybe you're dipping in an area where majority of the specimen are not there, they're suspended at the bottom of the urine sample. Over dipping of reagent strip has to be avoided. This one we already gone through. Okay, now this is something very important. Example, the parameters are color, for example. So example, in this case, we talk about the color. Normally, this is the color of the urine. But what will happen if it is abnormal? This is not a part of our lecture today, but just to give you an emphasize. So if it is dark amber, it's a concentrated urine, insufficient of fluid intake, maybe diarrhea, could be any other reason. So cloudy, dark orange is a reason, drug or pyridium is there. Red or dark brown is disease process causing blood in urine. So these are different options, different normal versus abnormal, and how we use all these parameters. For example, we have the specific gravity. So normal is 1.10 to 1.025. But if it is over 1.1025, it is diabetes mellitus or underhydration. If it is under, then it's a diabetes insipidus. So this, if you see here, diabetes mellitus versus insipidus versus your level of specific gravity. So these are different conditions versus their values in normal units versus the abnormal units. So it always keep on varying. So remember this part very clearly. So this is just an example. Okay, now we go to the most interesting part, which I found when you are all in the lab. You normally take a long time and you enjoy a lot looking at the urine microscopy. So we have the white blood cells, which is a reflection of infection, and we call it pyuria, which is the reference to the presence of elevated number of leukocyte or pus in the urine, that is the granulocyte. It could be a reason of upper or lower UT infection, glomerulonephritis, vaginal and cervical infections, external urethral matters for in man and woman. Normal range is 0 to 2. HPF stands for high power field. 5 plus high power field refer to the microscopic, the high power field. So 5 plus indicates an infection and 10 plus indicate more severe conditions. So when you look into one specific field at a high power, 40 or 100, normally you don't go for 100, but normally you go for 40 is still okay. 10 is still okay, but normally we prefer 40. So we will find that if its cells are more 5 plus, it indicates an infection. 10 plus is a severe conditions which need to be adjusted as soon as possible. Epithelial cells, normal urine, there is no epithelium present or they are unquantified. In renal, tubular epithelial cells, usually larger than granulocyte, contain a large round or oval nucleus, are normally sucked into urine in small amounts. It is positive in case of nephrotic syndrome, conditions leading to tubular degeneration. But normally 1 to 2 or 2 to 3 epithelial cells are still okay and they are normally acceptable, because we don't know it's coming through the by issues with the urine sampling basically. Okay, urine microscopy, we have the urinary crystals. Normally urine present in normal urine, crystals are present but are unquantified. There are different types of crystals. We have the calcium oxalate crystal, triple phosphate, amorphous phosphate, uric acid crystals. Within uric acid crystals, which is basically we have cytosine, we have the tyrosine and leucine crystals, and elevated number of crystals may indicate either hypercalcemia or number 2 cysteine crystals are reason of cystinuria. So remember, these all crystal is a characteristic of the pH of a urine. The pH of the urine vary, and then the molecules will turn into form of different crystals. So high crystals means basically it could be hypercalcemia, it could be cystinuria, or maybe other renal disease and renal failures. So every disease or failure might have their own type of specific crystals because of the change in the pH of the urine. Okay, now we go to the urine microscopy. We have the cast. It is formed at the distal convoluted tubules or the collecting ducts. Okay, this slide is very, very important from the examination point of view. I really want you to read this topic separately for 5 minutes. Just Google it out, and you have to read some terms like what are the proteins which are involved in synthesis of cast, and normally they are formed in the distal convoluted tubules or the collecting duct. They're the protein-based cylindrical molds of the renal tubule. It's a result of damage to the renal tubule, can contain cells and other materials. Dehydration and acidic urine normally predisposed to cast formation. So what actually is happening, if you see here, there is a example is basically a group of proteins. This group of protein has a very specific name, and this one I will leave to all of you. You have to basically read it. That's why I purposely leaving that part. Only a very small term is there. So you have to basically read this protein, and you have to tell me, not tell me, but at least you should know like what is the name of this protein and how the cast formation happened, because it itself is 1 to 2 hour lecture, but because we are not targeting for the timing. So you have to talk about what are different kinds of cast in the urine. And for example, generalized classification, we said there are cellular cast and there are non-cellular cast, and what is the protein involved to make this cast formation, and then what are the reasons these casts can be used for different kind of examination. So in urine, we have the urinary bacteria, abundant normal microbial flora of the vaginal or extraurethral matrix, ability to rapidly multiply in urine standing room temperature. However, it should be interpreted in view of clinical symptoms. Bacterial culture must be done in case of bacteriuria. If it's a very strong bacteria, it's ideal we should go for bacterial culture so that we know the exact bacteria to treat it. Okay, well, now we go to the urinary yeast. Sometimes the yeast cells may be contaminants or represent a true yeast infection, often difficult to distinguish from red cells and amorphous crystals, but can be distinguished by their tendency to bud. Most often they are candida, which may colonize bladder, urethra, or vagina. Okay, now non-bacterial organism, general crud or unidentifiable objects may find their way into the specimen, particularly those that patient bring from home. Spermatozoa can sometimes be seen. Rarely, pinworm ova may be contaminated in the urine. Ova from bladder infestations with schistosomiasis may be seen in the urine specimens. Okay, these are some of the pictures. I'm sorry, we are just finishing up the lecture because we have another 4 to 5 minutes left. So these are few of the pictures. I cannot be explain all of these pictures to you, but just have an overlook. Example, the first picture is basically the WBCs in the urine. WBCs in the urine. Second BC is the WBC cast. So if you remember, we said cast formation is like a protein. So it's a cast with lot of WBCs inside. The third picture is again a WBC with the cast here. So you got a lot of WBC within the cast. Then we have the mixed cast urine, because mix anything which is not defined, identified, it becomes mixed cast urine. So this is a mixed cast urine. And then we have the cellular cast. You know, these are the cells because the nucleus are non-nucleated, but we are not sure what kind of basically cells are these basic. So we call them cellular cast. So then we have the non-renal epithelial cells. Non-renal epithelial cells, it could be coming from anywhere else. So these are non-renal epithelial cells. Then we have the urinary oxalate crystals in this picture. These are urinary oxalate crystals. Normally what we do, when we use the microscope, we use the fine tuning, the fine focusing. So when you increase or decrease the light aperture of the microscope, you can see these kind of cross, Example, urinary oxalate crystal is having a specific cross. This is the cross which you can see here. So that is how we normally identified a crystal based on the diagonals of the crystal inside, which can be easily seen with increasing or decreasing the light. So then we have the WBC and RBC in the urine. So you can see the WBCs and RBCs in the urine. Then we have the squamous epithelium cells in the urine. So this is how we normally go through for the microscopy part. And then we have the bacterial and WBCs in the urine here. Uh, you can see the bacteria and WBCs in the urine here. So these are all the red small parts, the bacteria, and the big one is the WBCs. Okay, then we have then the mucus. This is whole mucus. This is whole mucus inside the urine. Then we have the budding yeast. You can see here the budding yeast inside the urine. Then we have the hyaline cast. This is all the hyaline cast. It is having its own function which you need to go through. These are the red blood cell cast. You remember the red blood cell has no nucleus inside. So this is a cast with the red blood cell. So you have to also tally the results with the previous physico-chemical, chemical, and the what we call the microscopic examination. The other examination which we have gone through, the previous three parts, and then you basically analyze three of all of them together. Otherwise, sometimes you cannot define the specific, the features in the microscopy. So you need to go back to all the previous research. So this is the white blood cell cast here, another example. Okay, this is the coarsely granular cast because this is, if you see here, we are not sure what is this one, but it's something seems to be granular. And we have the waxy cast. This is a waxy cast. All of them are reflection of different kind of metabolic issues, which is a reflection of different issues with the kidney or your body. So we have the amorphous urates. These are the amorphous urate. Okay, now we have the uric acid crystals. We previously had the calcium crystals. Now this is a uric acid crystal. So if you see here, when you change the light, it will give you a different outlook. So these are basically we call them uric acid crystals. Then again, going back to the calcium oxalate crystals, see a very difference is the calcium oxalate crystals. So they are both different from each other. Then we have amorphous sulfate. Then we have triple phosphate crystals. So this one is totally different from this one and from this one. They're totally different from them. And then we have ammonium urate crystals. Then we have calcium phosphate, calcium carbonate crystals, tyrosine crystals, cysteine crystals, not cysteine crystals. And then we move on to the next slide. We have the leucine crystals, cholesterol crystals, sulfur crystals. Okay, then we have the fecal material which is coming inside your urine specimen. So these are fecal material. Then we have that, some people use a lot of powder, that talcum powder. So when they come to give the sample, so sometimes even in the urine specimen, all this powder come in. So we sometimes become very confused, like it's epithelial cells or whatever is this one, At the end, it is basically just a talcum powder. We call it talc in urine. So you have to be very clear. That's why we need to instruct the patient or the normal person in a very nice way how to give a urine specimen. They have to wash themselves first, whatever the instructions, and then like midstream urine sample, how it should be. We have to be very clear with them. Okay, sometimes the starch come in the urine. Okay, cotton fiber in the urine. Sometimes, some people are wearing specific clothes and, the cotton fiber also come inside the urine. And this is another example of the cotton fiber looking like a big cast, But if you change the luminescence, the light, you change the light, in the microscope, you can easily differentiate between the cotton fiber and basically the cast. So then we have the epithelial cells in the urine, another example. So it's a very interesting, it's a very nice actually analysis if you really are into urinalysis and you really want to study it properly. Otherwise, you cannot see all these things in one urine. So these are just a lot of collection from different specimens. But when you are going to do it, maybe the sample you're going to get, maybe there will be no abnormal microscopic finding. So requesting a urinalysis, if somebody is having burning urine, difficulty in urination or painful urination, semen in urine with great exhaustion, if it's a backache early morning, infection or renal stones, it's a fullness of kidney pelvis. If it is a UTI, it's a Korean females, spread of infection in the urinary tract, and then we have the fatigue and exhaustion, lower abdominal pain or suprapubic pain. So these are some of the signs and symptoms when you need to request a urinalysis. And that is all. Thank you so much for listening and being attentive. I'm sorry I have to rush in the last few slides because we have a total of 1 hour and we have to finish everything within that 1 hour. So still, I'm happy to take your questions if you have any questions. Otherwise, you know my office, you know my email, you know my phone number. You can anytime refer back to me, inshallah. So that is all for me. If you have any questions, please let me know.